Welcome to Global Fatty Liver Day 2024, presented by the Global Liver Institute. This day elevates awareness, education, and engagement around the growing prevalence of fatty liver disease worldwide. I'm Jeff McIntyre, Vice President of Liver Health Programs at the Global Liver Institute, and today we are here in Richmond, Virginia at the Virginia Commonwealth University Stravitz-Sanyal Institute for Liver Disease and Metabolic Health to discuss the critical role that healthcare systems and institutions play in enhancing and scaling effective models for better outcomes in patients with fatty liver disease and its advanced stages. I'm thrilled to be joined again this year by Dr. Arun Sanyal, the director of the Stravitz-Sanyal Institute. Dr. Sanyal, thank you for joining us today.
Jeff, it's a pleasure to be on this program.
Yeah, excellent. So over the course of its history, this campaign has partnered with over 220 organizations representing more than 75 countries. Our theme this year is Act Now, Screen Today, which highlights the importance of early detection, screening, and intervention in combating this disease. So, Dr. Sanyal, let's get started off here a little bit. I want to talk about the current state of fatty liver disease in the United States. How has the prevalence or the approach to this condition changed over, say, recent years?
Well, the prevalence continues to creep upwards, so that almost 50% of the adult population has excess fat in the liver. Importantly, the more aggressive form of steatotic liver disease, the one where you have inflammation and injury to the liver called steatohepatitis, that seems to be increasing. And it is projected that by between 2040 and 2050, we will double or triple the number of people living with end-stage liver disease. This is way more than can be handled by transplant alone. And so this is really a very serious public health threat. This is further compounded by the fact that the majority of people who present for the first time with a complication of cirrhosis due to this condition, that is also the first day that their liver disease is diagnosed. Now, cirrhosis doesn't happen overnight, right? So that means this condition has gone undetected for decades, likely, before it got to this point. And this really highlights the theme for today. We need to find these people where the disease is still early in its course, before it has done serious damage to the liver, so that we can stop the ship and turn it around before it's too late.
So in response to this, a while back, there was a big grant to VCU and was the creation of the Stravitz-Sanyal Institute here. Now, when we last did that, there was a lot of excitement. There was the new funding, there was the plans for extended outreach. Talk a little bit about the center, about its response, about kind of what you have going on here. What are the priorities for the center going forward now?
It's really threefold. First, to promote and create a platform for ongoing research, so that we need to continue to learn, and we will continue to learn. But it's not just for me, it's really creating a platform for generations of investigators to come and be able to continue the work that we started. Number two is clinical care. It's one thing to do the research and generate the knowledge, but if we don't translate it to help patients with liver disease, then it's just an academic pursuit in an ivory tower. That was never the intent. So with that in mind, we have already started aggressive screening processes. We particularly are delighted that our partners in primary care in the Women's Health Center have become early adopters, and we are aggressively screening many of those patients. We are also expanding the footprint of the care that we provide beyond the liver to encompass the other things that lead to excess mortality in this population. I'm particularly talking about preventive cardiology, and we have two individuals who have joined the team to support our preventive cardiology efforts. We have recognized the critical need of behavioral sciences, because at the end of the day, there are many reasons for the underlying obesity and adiposity that drive this condition, as well as the cardiovascular, diabetes, and other problems that occur. We now have somebody we're in the process of finalizing recruitment of a person who will be a critical member of this team. In addition to that, we now recognize that there are people who have metabolic risk factors, but who also engage in risky drinking. Risky drinking means consumption of alcohol at levels that are likely to lead to harmful liver disease or other end organ diseases. So we are aggressively working towards that and are working with our colleagues in addiction medicine to help those patients who need help both with the metabolic side of things and with the alcohol side of things. And then finally is really being able to translate the learnings from here to areas around the world. With that in mind, we have established formal memoranda of understanding with University of Sao Paulo in Brazil. And just last month, we had 15 senior professors of liver disease from all over Brazil come and spend a few days with us over here. And that will allow us to extend, when they go back and start teaching their trainees, that extends sort of the learnings to a much larger population. We have done a similar thing in India just a couple of weeks ago. And we have similar setup in Turkey. And we are planning to do a program in Singapore in July. So all of the things we're learning right here, we are almost in real time expanding into practice around the world. Another major partner for us is our Health Ministry of Mexico, and through them, clinics that are part of the federal health system. So many different activities around that as well.
So in picking up on point 3 there for the Institute, that's a great segue to the next question, which is about scaling this, about really reaching out globally. What do you see as the opportunities for better diagnosis and screening and treatment internationally? I mean, especially you mentioned several countries there of variety of sort of income levels, if you will, I guess, or mean income levels. So I'm curious about scaling this, especially for countries that are under-resourced or at risk. Are there particular regions where you believe that these approaches could make a significant impact?
Oh, absolutely. So you can have a Cadillac or you can have a Nissan. They both can get you from Richmond to Washington, and given I-95 traffic, probably in the same amount of time, right? So we do have a lot of tools. We're very fortunate. However, with a minimum set of tools that are nearly almost free. And one tool I do want to highlight is a laboratory aid that's called the FIB4. If you just look at the risk profile of an individual, if they're obese, if they're diabetic, there's a very high probability they have excess fat in their liver. So having fat in the liver is not quite as important in that setting as understanding whether the fat has started injuring and scarring up the liver. And so the FIB4, which is based on simple blood test that is available worldwide and is affordable in almost every health system, gives us a pretty good, quick and dirty first look at the likelihood that somebody has significant scarring in their liver. And this allows, even in very resource-constrained areas, to allow screening of people with clinical risk factors, to identify those who need something a little bit more. And of course, drug development is ongoing, and eventually there will be drugs that will be available. There are also drugs that are available all around the world for which there is evidence for off-label use. They're not approved by the FDA, so it's off-label use, but they could be used in select individuals around the world. So there are many, many options. It is a very different scenario in 2024 than even in 2023.
And we've seen that a little bit with the recent indications for some of the GLP-1s, for instance, are now being indicated recently for cardiovascular whatnot as well. I think we're all looking forward to that day that fatty liver disease and NASH catches up with that, if you will. And speaking of that, one of the most talked about developments in liver health is, you mentioned FIB4, is the non-invasive testing for this as well. And potentially combination testing, I think, as well. How do you see these technologies here in 2024 changing the management of fatty liver disease? what would you consider barriers to more widespread adoption of these technologies?
I think the first one is the availability of elastography as a tool, because it requires special dedicated instrumentation. So certainly in the liver practices around the US, it is pretty much available universally. Many GI practices have them. Probably if you go down into diabetes and primary care, it's still very spotty. So in those settings, and that's where most of the patients are,
Right.
we have to start with something simple and figure out who gets sent for a elastography-based test. And a FibroScan is a reasonable second test to do. And in individuals where you cannot do a FibroScan, MRI is an option. But certainly between a FIB4, a FibroScan, and also now the approval of the ELF test, which is a blood-based test,
Right.
which actually has been approved by the FDA for risk stratification, we can find the individuals who have the highest risk of having a liver outcome, so they can be appropriately triaged for more advanced care.
Right.
So between these, I think we should be able to find people who are earlier in the course at risk of progression and those who already have progressed. And so I think we're in a pretty good position right now to use these combination of NITs to optimally identify, risk stratify, and then manage the great majority of patients with this condition.
So GLI just released, as we released this video, a best practices in liver health policy report when we hosted a side event with EASL at the World Health Assembly in Geneva. I want to talk about policy for a little bit, where you're comfortable. What do you see as helpful policy changes to support better outcomes for patients with fatty liver disease? Are there specific changes that you feel are necessary in healthcare systems, for instance, to better address this issue?
So policy can be defined at the level of institutions, states, nations,
Agreed.
and globally. So each one, the answer is a little bit different.
Okay.
I think if I start at the top globally, I think we have to understand that just as liver disease burden is increasing, chronic kidney disease burden is increasing, cardiovascular mortality is increasing, and many health systems worldwide, nationally, are unable to create entire infrastructure for each organ one at a time. Given that there is common biology linking all of these end organ diseases, given that when the liver disease progresses, all the other diseases are progressing as well, it is very important to start viewing these individual end organ diseases in a more holistic construct under the larger umbrella of metabolic health. In fact, we named our institute the Institute of Liver Disease and Metabolic Health in recognition of the fact that we don't want this to be a one-off, just looking at one organ in isolation. While our focus is the liver, but we also understand the care we provide has to be integrated with everything else that's wrong with the patient. That has common biology at its root. So I think from a larger perspective, getting recognition of the steatotic liver disease as part of the spectrum of non-communicable diseases under the umbrella of metabolic disorders is going to be extremely important. At an individual institution level, I think barriers for family practitioners and diabetologists to screen and to get reimbursed for those kind of tests is going to be exceptionally important. In my conversations with diabetologists and family practitioners, we are faced with the challenge that the current practice guidelines for family practice do not yet recommend routine evaluation and screening for steatotic liver disease. So getting a hepatic panel is considered out of standard of care, for example. So they're even unable to get a FIB4 in some instances. So I think that has to change. We have to engage the US Preventive Health Task Force. They have to change the way they think about these diseases. We cannot wait 25 years to generate the high level of evidence they need before they'll make a recommendation. Because the data is already out there, and we are seeing this in our clinics every day. It is incredibly important to be able to identify people earlier in the course of the disease when we can manage these patients relatively easily, rather than wait for them to get cirrhosis and then deal with them.
You know, you and I are in a lot of meetings together. NIH, ASLD, EASL, we bump into each other in many, many hallways. And so often the conversation is fatty liver disease, its process, its guidelines, this or that. One of the questions I've always wanted to ask you is, in your time in working in the field, what would you say are some of the most significant lessons you've learned about engaging and treating fatty liver disease? Is there advice, or what advice would you give to new clinicians and researchers that are just kind of coming into the field? They're just entering into this grand field.
Well, that is a really interesting question, because there a lot of learnings, obviously, but just to pick on a couple of high-level ones. One is, of course, as in any other body of research, if you're going to be a scientist, you have to be resilient. You have to learn to accept rejection, because the default mode is usually for people to reject your ideas. Right. And so you have to come back with evidence and data. So don't take no for an answer. If you truly believe in what you're doing, generate the evidence and let the evidence lead you. For the clinicians, my best advice I can give you is, even more important than reading papers, is actually listening to your patients. Physicians, unfortunately, are not very good listeners by and large. We're too busy telling the patients what's wrong and what needs to be done. And half the time, we haven't really heard what the patient really wants. The patient is why we're there. And the first step is to sit down, take the time, take a breath, make eye contact, and actually ask the patient what brings them to your door and what would they like to see as a good outcome, what's bothering them. And I think the patients will tell you what the best questions are, where the science needs to go. And listening to the stories of patients who were told that they had minimal liver enzymes, irrelevant, a little bit of fatty liver, everybody has fatty liver, don't worry about it, to overnight turning that conversation into, I think you should see a liver doctor, we think you might need a transplant. And this happens on a weekly basis. Right. And not just at my center, but in talking to my friends around the country, this happens everywhere. We have to change that paradigm, and the only way that will stop is to actually include the patients in the conversations with our colleagues, with clinicians, particularly those who are naysayers.
This is why we love working with you, is that we want to have those patients included at every stage.
I could not be a greater supporter of that.
Excellent. So let's look ahead a little bit. When we take a look at all the different areas of research that there are around liver and metabolic disease, especially as well, what do you think are the most promising areas of research around fatty liver disease? And maybe not most promising, but what are you most excited about seeing? What is interesting? We see a lot of things, AI gets thrown out, people get stars in their eyes, non-invasives, what's most promising and what are you most excited about?
So I'll give you my disclaimer up front. The disclaimer is that many of my colleagues, to me, it looks like children trying to play soccer. They're all chasing 12 kids running, chasing the ball. So whatever's the newest, shiniest thing, they go. So, let me discount that whole AI. AI has a role just like everything, right, and it will eventually be figured out. I tell you what excites me. What excites me is the incredible progress that is being made in generating the evidence to support the use of non-invasive tests, to identify patients, to risk stratify, and then to be able to evaluate whether their disease course or disease trajectory is changing with treatment or without treatment. That gives us so many tools now that as we translate that knowledge, literally anyone in any clinic should be able to use in the future. So that really will be transformative, because it will impact each and every person who has the disease. Yeah. And that's the goal, right? The second exciting thing are what's happening in therapeutics. So this year at the European meeting in a few weeks, we will show data with 2 different second-generation GLP molecules, showing remarkable, if I may be a little histrionic, even almost hepatitis C treatment level responses.
Big words.
Those are very big words. Because, we got spoiled with hepatitis C.
Yes.
Because we, from going to having minimal progress, we now can cure, hepatitis C in just about everybody. Mm-hmm. It's easier than treating a urinary tract infection in many cases. But really remarkable progress. And we're beginning to shift the needle on fibrosis in a big way, that's always been a stumbling block.
Right.
Because even when we made progress on improving the NASH, we had trouble getting the fibrosis to shift. But the new agents actually are making progress in that front. Very exciting data with efruxifermin's 96-week data showing 75% of people had regression of fibrosis.
That's really remarkable. I mean,
that is spectacular. It's beyond remarkable.
It is. Well, it's also, where the cup overflows, if you will, at that point. And if you can figure out how to stop that cup from overflowing, that's the demarcation point.
Exactly. Where we have not made progress is cirrhosis. And my personal belief is that's because people have been asking the wrong questions. It's a major area of interest for us and focus of our research to find out why we have not made that progress, because I think there's a lot of additional biology that goes into play once you progress to cirrhosis. It's no longer a simple function of the scar tissue and the steatohepatitis. But, that's for the future. That's what we're focused on trying to sort out. And hopefully we will do that. But it also underscores, since we have not made progress in the cirrhotic population, the idea that you let somebody progress to cirrhosis before you think about intervention is absurd.
Yeah, absolutely.
You have to catch people earlier because we have effective therapies and tools.
Especially with so many co-occurring symptoms.
Exactly. Exactly. We already know that the GLPs will improve, high-risk populations, all-cause mortality, glycemic control, cardiovascular, renal function, maybe even neurocognitive decline. And now data is coming that they can help the liver as well. So I think there's so many products from the resmetiroms, thyroxine beta receptors, second-generation molecules are on their way, the GLPs, which are rapidly expanding as a class, the FGF21s. So there's a lot going on and looking good.
There's a lot of optimism and a lot of good potential there. So finally, I want to talk about the creation of the Stravitz-Sanyal Institute for Liver Disease and Metabolic Health. I think I got it all in there. Here in Richmond at VCU. It was really a momentous event. And to end our Global Fatty Liver Day conversation, I want to do a quick thought exercise with you, if you will. So we were fortunate to be here with you last year. Fortunate to be here with you today, this year, 2024. So you and I are sitting here in 10 years, 2034, which doesn't seem like a real year to me quite yet. What will we be saying when we're asked about what the state of fatty liver disease is in 2034? What victories will we be celebrating, and what are the challenges in 10 years that we're going to be looking at then?
I think the biggest victory we'll be celebrating is that I think we will be able to reverse steatohepatitis in 90% or higher patients. At the same time, we'll be able to reverse fibrosis in 70 to 80 or upwards of 80% of people, in the majority of people. And at the same time, we will be able to improve the cardiovascular, metabolic, all the other risk factors. So I think we will have won all of those battles. We'll probably even have made some progress on cirrhosis by then. Where I think the challenge is, what we'll be talking about then, is do we really have to let people develop disease before we intervene? That makes no sense to me at all. It has never made sense to me that in the United States we spend $600 billion a year. These are data from the CDC. If you add up all the different metabolic health and organ disease and how much we are spending on them. But this is all based on a paradigm of people developing disease and health systems then bringing them in, which is really a Band-Aid in many ways for many of those conditions. Would it not make sense to spend 20% of that money up front and develop a healthier lifestyle for all and engage in better way of living and maintain all of these people in the workforce? We haven't even counted the number of people we lose from the workforce in the most productive years of their life because of these end organ diseases.
Yeah, absolutely. We've got to catch this, solve the problem at hand and then be able to go upstream to be able to see kind of what's causing everything to flow down to us as well. Absolutely. Thank you, Dr. Sanyal. It's always good to catch up
It's
with you
always good
as
to
well.
talk to you.
It's always good to get your thoughts on kind of the state of liver health, where we're not so dictated by the agenda of a given organization or meeting or something like that. I want to thank the great team here at Virginia Commonwealth University in Richmond for helping facilitate this conversation and for your support of liver patients and Global Fatty Liver Day every year. I want to give a special thanks and shout out to my colleagues back at the Global Liver Institute for the work they do on this day and every day on behalf of liver patients. For more information about the Stravitz-Sanyal Institutes for Liver Disease and Metabolic Health at VCU, check them out online at liverinstitute.medschool.vcu.edu. And for more on the worldwide happenings on Global Fatty Liver Day, you can find us at globalfattyliverday.com or the Global Liver Institute at globalliver.org. I'm Jeff McIntyre with the Global Liver Institute with Dr. Sanyal. Thank you so much again.
Thank you so much, and thank you, GLI, for being such a phenomenal partner in this journey.
Excellent. Act now, get screened today, and enjoy Global Fatty Liver Day.